Regarding atypical fractures, these are low energy femoral shaft fractures with a characteristic appearance. This can be caused by the varus deformity, anterior bow, or impaired bone healing and remodeling. As per the definition, there are at least 4 major criteria which can cause a diphyseal femoral fracture to be atypical. Number 1, minimal or no trauma. Number 2, fracture origin from the lateral cortex and is substantially transverse in orientation. Complete fracture may be associated with medial spike. Incomplete fracture with the lateral cortex only. Number 4, fracture in non-comminution and minimally comminuted. Number 5, local periosteal or endosteal thickening present on the lateral cortex. There are certain minor criteria, that is, number 1, generalized increase in cortical thickening, prodromal symptoms of thigh pain, bilateral incomplete or complete fractures, and delayed fracture healing. So practical definition is low energy subtrochanteric femoral fracture associated with the biphosphonates use with a characteristic set of features. Regarding the pathogenesis, insufficient fractures can happen because of unfavorable mechanical environment or impaired bone healing, or both. Regarding biological factors, a normal microfracture repair happens with callus formation and then after rank-mediated osteoclast action causing remodeling. The rank L-mediated osteoclast remodeling is not present in these fractures. Many studies have linked bisphosphonates use causing atypical femoral fractures. Some case reports of denosumab use with rank L inhibitors causing atypical femoral fractures. The risk factor patients are old age, female, Asian, or Hispanic, and with a genetic gene mutation of GPS1 mutation. The first line of treatment for osteoporosis is bisphosphonates, which are major risk for atypical femoral fractures. It's quoted that increased duration of use of bisphosphonates of more than 5 years, and some studies 8 years, will increase the risk of bisphosphonates-related fractures. The two studies to quote is a FLEX study that continuing alendronate for after 5 years of use decreased bone loss versus compression fractures. Horizon study showed continued zoledronic acid use for 3 years year of use decreased bone loss, cause vertical and not reduce the risk of vertical compression fractures, but not other fractures. Alder et al. Has quoted that bisphosphonates should be discouraged after 3 to 5 times. So in such fractures, I will do investigations like X-ray. May need MRI to diagnose a development lateral stress fracture in cases which we want to do a prophylactic fixation. X-ray will be shown, which shows peaking of the lateral cortex and maybe a deformity like a varus deformity. So the main line of treatment would be a prophylactic IM nail along with endocrine consult. The problem with the surgical fixation is that after putting a fixation with the anterolateral bowing of the femur, there will be a poor nail fit. Number 1. Number 2, lateral cortex may be thickened and may deflect the nail medially, causing varus deformity. Then poor bone quality because of pre-existing conditions and delayed healing, so the construct should potentially survive the long period of time. So for anterolateral bowing, how to address this? When you are doing nail, you choose the smallest size of the nail with respect to radius of curvature. Number 2, you can external rotate the nail to improve the nail fit. As there is anterior bow, when it is external rotated, there is an anterolateral bow and possibly improve the fit. Number 3, medialize start point to avoid varus malreduction. For localized cortical thinning at the fracture site, we can, number 1, use reamers to drill the lateral cortex thickening. Other way around would be use a awl or a rigid the Sean's pin or a ball spike pin to move the proximal fragment more medially and then try to ream the lateral thickening of the cortex. The prognosis regarding it is the Gusti et al. Ensured that the non-union rate is up till 30%.